Hello friends, welcome back. Today I shall talk about the Hepato-Renal Syndrome. As the name itself suggests, hepato, then the renal, it all starts with the liver basically. Once the liver gets messed up, it leads to multiple pathophysiological changes, which basically leads to renal failure. Today we shall focus on how the damage to the liver leads to kidney damage. Earlier I posted a lecture on splanchnic portal circulation where I mentioned about the changes in the volume of the blood being distributed to different parts of the body. My objective today is to talk about the pathophysiology of the cirrhosis, the some renal physiology, and about the net filtration pressure, diagnosis of hepatorenal syndrome, and the subtypes of hepatorenal syndrome. We will start with a case who was diagnosed with hepatorenal syndrome. This patient had cirrhosis with ascites, a 37-year-old young male with a past medical history of alcohol disorder. He was admitted to hospital due to vomiting with blood. I'm not going to read the entire paragraph. I'll just highlight what were the observations. This patient was hypotensive, he was hyponatremic, uremic, oliguric, and he had acute kidney injury with ascites. The patient had cirrhosis with the recanalization of the umbilical vein, and he had esophageal varices. Patient's abdomen was distended. It was tender to palpation on the left side, presence of ecteric mucous membrane, and he had presence of astraxis. Patient's labs show elevated INR of like 3.8, PT44, hemoglobin 6.2, pulse 67, temperature 97.9, respiratory rate 18, and height 4 feet 11 inch, weight 84 kg, BMI 36, oxygen saturation 100%. He was producing stools. Now they did the therapeutic paracentesis, and they removed about like 3.5 liter of the clear yellow colored fluid. Once they did the paracentesis, his sodium level fell to 114 MEq per liter. I made a typing mistake here. I put ME per liter instead. It should have been ME, milliequivalent per liter. He was then infused with normal saline, which basically actually did not help in changing the urine output. Next day, when the ultrasound was done, it showed re-emergence of the acidic fluid in the abdominal cavity. Patient became more edematous and he gained some weight. Now there was a leakage from the paracentesis insertion site. Uh, Patient was hypotensive. He remained hypotensive. He was transfused with the 4 points of fresh blood, which temporarily raised his blood pressure. Eventually, he was started on norepinephrine infusion, and the dose of norepinephrine was actually titrated up to raise the mean arterial pressure by 10 millimeter mercury. This is a basically complicated case to discuss the pathophysiology. I'll just start with the cirrhosis actually. Uh, Now basically what happens because because of the cirrhosis, there are multiple physiological changes which occur in the body. Cirrhosis plays a central role in causing the hepatorenal syndrome. What happens in the cirrhosis, the liver basically shrinks in size. It becomes hard and like a stone. And these are fundamental permanent changes due to fibrosis of the liver. Fibrotic tissue doesn't work. It doesn't allow the blood vessels to open up. So the blood vessels, they don't expand. So and gradually the blood is not able to basically pass through the liver, and gradually the resistance inside the resistance of the vasculature inside the liver start going up. So slowly this pressure start building up. Normal pressure is somewhere around like 5 to 6 millimeter mercury. Pressure greater than 6 millimeter of mercury can lead to portal hypertension. Even though there are other causes of portal hypertension, but today we will discuss more about the intrahepatic cirrhosis, basically portal hypertension because of the intrahepatic region. Other reason could be pre-hepatic or the post-hepatic obstruction. What happens during portal hypertension? The patient develops some kind of hyperdynamic circulation in which instead of having generalized vasodilatation throughout the body, there is a more selective vasodilatation of the arterial splanchnic arteries actually in the GI area, and this is more due to kind of cirrhosis induced nitric oxide production. There are some triggering factor which can precipitate this splanchnic arterial vasodilatation, like during large volume paracentesis, presence of spontaneous bacterial peritonitis, or hypovolemia, any kind of GI bleeding, or use of non-steroidal anti-inflammatory drugs. Bacterial translocation seems to play some role here as well. Now, as a result of splanchnic arterial vasodilatation, the systemic vascular resistance decreases. Therefore, more blood basically goes to the gastrointestinal area, whereas the rest of the body gets reduced blood supply. This results in low effective arterial perfusion across the kidney. Now, once the pressure across the kidneys drop, the kidneys start shutting down, and this whole cascade of adverse event lead to development of hepatorenal syndrome. I want to focus a little bit more here on the filtration pressure in the kidney. Why? Because what happens in the hepatorenal syndrome patient, the kidneys could be perfectly fine. The problem is not in the kidney, the problem is in the liver, because when they procured kidneys from the hepatorenal syndrome patient and they transplanted those kidneys to patients with the kidney disease who were on dialysis, those kidneys work just fine. So the problem is in the liver, not in the kidney. So understanding how we can protect the kidneys if we intervene early enough, is any way we can do it? Probably yes, So I mean, that's why I want to focus a little bit on the about the perfusion pressure in the kidney, basically because the kidneys fail because of the low perfusion pressure. So it's important to understand the perfusion about the perfusion occurring in the kidneys. So let's take a look at the nephron. This basically here the afferent arteriole is bringing the blood inside the glomerulus, and the efferent arteriole is taking the blood away from the nephron. The incoming glomerular hydrostatic pressure is about 55 millimeter of mercury, and the osmotic pressure, or you can call oncotic pressure, because of the colloids like albumin, is about 30 millimeter of mercury. The pressure which is exerted by the Bowman's capsule from the outside, I mean the Bowman's capsular pressure about 15 millimeter mercury, and from these three different pressure we can calculate what is the net filtration pressure, which would be the difference of hydrostatic pressure of the blood in the glomerulus minus the sum total of hydrostatic pressure of Bowman's capsule and the osmotic pressure of the colloids in the blood. This is the net filtration pressure, about 10 millimeter mercury. This is a kind of magic number, as I mentioned earlier, because when we treat these patients using the vasopressor, we try to raise the MAP minimum by like at least by 10 millimeter of mercury. um, because this is kind of is a net filtration pressure which you need to have it so that kidneys can filter out the unwanted stuff and make some urine. Usually our blood pressure can fluctuate within a certain range, and the pressure across the kidney, filtration pressure across the kidney, does not change unless there's a significant drop in the incoming pressure, which could be any reason. For example, patient lost a lot of blood due to some accident, or there's a shock like a hypovolemic shock, or any reason technically leading to low perfusion across the kidney uh, leads to kidney failure. The kidneys can basically start shutting down once the perfusion pressure across them decreases. It depends upon the severity of the shock too. If the shock is not severe, probably they can handle, kidneys can handle for a little longer time. If the shock is too severe, and they will shut down much earlier. Depends upon the patient's age, patient's health, and other any other factor patient might have it. So generally the systolic blood pressure is we need the systolic blood pressure around 90 or higher. Less than that can like compromise the perfusion across the kidneys. So when we use the vasopressor, that's the idea of raising the like mean arterial pressure. Now, when you, when we use the when the pressure across the kidneys actually drops, body I look at it in this way, like kidneys basically can handle the shock for a certain time, because think like this, kidney can sacrifice themselves for certain period of time, because the body wants to divert the blood to more important organ like the brain, heart, or the muscle. Why muscles? Because in emergency you never know, you might need to run away from the situation. So we need to have certain minimum supply to the muscular skeletal system. So when the kidneys can handle for a certain time, like the kidney can sacrifice for certain, but if it's too and if in the meantime the treatment is received, given to the patient, probably we can save the kidney. But if it's too late, then they will shut down permanently. And a body actually try, in order to prevent the kidney damage, body actually try to in the hypovolemic shape condition, body try to secrete, they call hypovolemic hormone, in order to compensate the volume. Basically think like this, like if we lost some lot of blood, and body want to retain volume, where the volume is going to come. So in a way, let's say the brain is telling kidney, hey kidney, you were wasting uh, you were wasting water. I need to hold on to the water. Why are you making urine? Please don't make any more urine. Stop. And we need to hold on to the, well, that's what kidney does. So that's why the flow to the body actually secretes the anti-hypovolemic hormone, try to cut down the blood supply to the kidneys, and secretes compensatory hormones. And as soon as it detects the low effective arterial blood volume going through the kidneys. So in a way, anytime the renal hypoperfusion is detected, body activates adrenergic system by, once the arterial baroreceptor detects fall in pressure, and at the same time body releases antidiuretic hormone, whose job is to retain the water basically. Or and some the other condition is, whenever the blood becomes too thick, they become hyperosmolarity, body releases antidiuretic hormones. So the ADH is basically going to do water retention. And what happens is when you body retaining free water, whatever the osmolarity of the blood was, it will get diluted. So the plasma osmolarity decreases now. So in a way, ADH, besides uh, we are more interested here in building up the volume. So ADH is holding on to the water. That's how it's able to raise the effective arterial blood volume actually. Now when the baroreceptor sense the fall in pressure, they activate the sympathetic nervous system, which actually causes vasoconstriction of the vasculature, and that's how it increases the systemic vascular resistance, a low blood supply to the kidney. In a way, kidneys are basically harming themselves, but this is mainly um, um, to save the other important organs. Similarly, renal hypoperfusion leads to activation of RAAS system, which is renin angiotensin aldosterone system. Now renin causes vasoconstriction, and aldosterone causes salt retention. So now whenever salt retention by increasing the sodium reabsorption. So basically whenever you see like more salt is a charged particle, so it being a polar, it will attract any other charged particle like water. So more sodium means more basically more sodium means more water actually, you know. So ultimately basically more water, in a way basically it's going to increase the extracellular volume. So the RAS here is basically doing three things actually. Number one, water retention. Number two, sodium retention. And number three, also vasoconstriction of the vasculature. And it's all just because of the RAS system alone. Similarly, the ADH is holding on to the water, whereas the adrenergic sympathetic system is increasing the vascular resistance. Therefore, if you put all these systems together, I mean the RAS system, the ADH, and the adrenergic system together, they all finally, if you add the net effect of all these three combined, they're trying to increase the extracellular volume actually. That's the whole idea behind this compensatory mechanism. Now, it all happened because it all was triggered because of the low effective arterial blood volume or low perfusion in the kidney. Like I mean, if the pressure if this somehow dropped, there could be some triggering factors which I discussed already, like presence of spontaneous bacterial peritonitis, or doing large volume paracentesis, or GI bleeding, etc. Or infection or shock. Depending upon how fast the damage to the kidney occur, we have divided Hepato-Renal Syndrome into two subtypes, type 1 and type 2. Type 1 is more acute, we also call it HRS AKI, is more acute, and severe damage to kidney occur generally within 2 weeks of onset. The serum creatinine doubles, become more than 2.5 milligram per deciliter in 2 weeks. These patients have very high mortality rate, very poor prognosis, unfortunately. About 80 to 95% of these patients, type 1 patient, die within 30 days. The median survival time is less than 2 weeks. And there are some precipitating factors which I already discussed earlier, like which can actually lead to rapid decline of renal function like the spontaneous bacterial peritonitis infection, GI bleeding, hypovolemia, large volume paracentesis, or use of non-steroid anti-inflammatory drugs. Type 2 HRS is more gradual and has a slower onset, and the median survival time is up to 2 months. And there are no precipitating factors for type 2 hepatorenal syndrome. Type 2 ascites is resistant to use of diuretics actually. uh, let's talk about a little bit about diagnosis. There's no one specific test that can establish the diagnosis of hepatorenal syndrome. The following definition and diagnostic criteria have been proposed for hepatorenal syndrome. For example, chronic or acute hepatic disease with advanced hepatic failure and portal hypertension, acute kidney injury, which is defined as increase in serum creatinine of 0.3 milligram per deciliter or more within 48 hours, or an increase from baseline of like 50% or more from the baseline within 7 days. The absence of any other cause for acute kidney injury, including shock, current, or recent treatment with the nephrotoxic drug, and the absence of ultrasonographic evidence of obstruction or parenchymal kidney disease, spontaneous bacterial peritonitis, or ongoing infection. In conjunction with the excluding other apparent causes of kidney disease, the following criteria also apply in diagnosing the HRS. For example, lack of improvement in kidney function even after volume expansion by using intravenous albumin. Normally we give 1 gram per kg of body weight per day up to 100 gram per day for at least 2 days, and and withdrawal of the diuretics. I know this is a lengthy topic, so I wanted to actually cover the treatment and management, but the lecture became too long, so I'm going to stop here. And in my next post, I will cover the treatment and management. Thank you very much for watching. Thank you.